I do want to shift gears now, and you kind of mentioned it, and I think you're really excited about talking about this, and rightfully so. I think we talked about the use of kind of advanced biomarkers, and you mentioned AI, and I think you just recently published an article in European Urology about the use of. Tell me if I'm saying it right. The CHI biomarker, it's CHAI, I think. But give us a little bit of overview, kind of what was the use, what was the need that you were trying to address when you guys came up with this concept. And I think it was a multi-institutional collaborative study that you guys just published in European Urology. Give us a little more background about that.
Yeah, absolutely. So, we talked in the very beginning that the standard of care for newly diagnosed high-grade disease is BCG.
Yeah.
Um, there's been a lot of practices where BCG has been in severe shortage, and we need a viable alternative. And gemdoce has been kind of used as a backup option in those patients. People started asking the question, well, these outcomes look pretty darn good. They're as good as BCG. Can I just use this on all my patients? It's not really recommended in the guidelines yet as a level one recommendation because we don't have the
Right.
prospective readout yet. But are there any other factors that I can use to help make this decision? So this test was actually first developed more as a prognostic signal for patients who are receiving BCG. So there was a publication a little over a year ago, over 1,000 patients from about 10 centers, where they developed and trained this AI model.
Mhm.
Again, microscopically zooming in on the index TRBT slide,
Yeah.
finding more than 700 microscopic features that are
Mhm.
associated with response to BCG, and it could nicely stratify um, risk of recurrence and progression and development of BCG unresponsive disease beyond traditional clinical pathologic features. So if you just plug in the AUA risk criteria or the EAU risk criteria score, this outperforms that. So it's finding some new signals than what we're
Got
seeing
it.
from our usual path report. Um, so, we used a lot of gemdoce for treatment-naive disease at University of Iowa, which is where I was practicing before I came to Rutgers. Partially just to be able to maintain our BCG supply. We would only get enough BCG to treat one or two patients a month, and we were seeing,
Mhm.
dozens of patients that needed treatment.
Sure.
And I collaborated with, Dr. Hensley. He's over at University of Kentucky. He found himself in a similar scenario where, because of BCG shortage, they were giving a lot of gemdoce. So we pulled those cohorts and we looked to see if the model could predict if someone was more likely to respond to gemdoce versus BCG, depending on the test result. And
Yeah.
basically, what we found was that if the test was negative, then patients had a much higher, patients had a similar response rate to BCG or gemdoce, basically 75% recurrence-free survival between both arms. But if the test was positive, patients had a really poor likelihood of responding to BCG, but still
Mhm.
had a good chance of responding to gemdoce. I don't think it's ready for clinical use yet, although the test
Yeah.
is clinically available.
Mm.
It does need prospective validation, and we're working on that. But it's another good piece of information, especially if a patient has a lot of interest in, steering their treatment decision making and wants more personalized care.
We're seeing a lot of these advanced kind of biomarkers pop up, whether it be bladder cancer, prostate cancer,
Mhm.
less so in kidney cancer at this point, but there is more of this happening, at least in the localized setting. And I
Yeah.
suspect this is probably one of those things in the bladder cancer that's going to become more and more used. What are the next hurdles for this? Like, what do you sense is going to be the next steps and the hurdles for this biomarker?
Yeah, I think we need prospective validation,
Yeah,
and we're hoping to do that, on prospective cohorts such as Bridge or
sure.
different SWOG trials. Um, Other spaces, like you mentioned before, we're starting to see more attention to different pathologic subsets. So intermediate risk disease, we're starting
Yeah,
to look at that avenue. BCG unresponsive disease, we have so many treatment options, and we often don't have a rational way of steering patients to different ones. And precision medicine would be important for that. So if this
yeah.
test helps us with that, it'll be very helpful.